actually, the best person who should give this talk is Dr. Tim Crazy. He's here. So if you have any question from my talk, just direct question to him. so just prepare your question. So we will answer that. Even though the TB is preventable and curable, but we still have a high mortality rate. As you listen to Dr. Vidya Mev just last hour, so you will see that we still have a high burden of tuberculosis. And you see here, so from 1.3 million deaths, so almost 107,000 HIV positive patients die from this infection, which we think that it can be treatable and curable. And also it can be preventable, especially among HIV patients. As you see here that for our HIV patients, they are up to 20 times more likely to fall ill with TB. And TB is also still the leading cause of death among this population. So just tell you a bit when we see the patient, we have to think two parts about TB and about HIV. So about TB, you need to give them anti-TB, which if possible, we would like to have Rifampicin-based anti-TB as much as we can, because for other non-Rifampicin-based regimen, so it's related to poor TB treatment outcome, and with the long duration of TB treatment, so it will affect to the adherence. And for the HIV, we have to think about when to start ART and what the best regimen for them. So with the ART, we have so many problems with additional toxicity, like hepatitis and rash, and also we have about the significant PK-PD interaction between Rifampicin and also ART. So now we don't have the debate when to start ART, right? So from the US side, they recommend CD4 less than 50 cell, ART should be start as soon as possible or within 2 weeks of starting TB, because the very low CD4 cell counts increase the risk of death. And for CD4 higher than 50, so it can be treated within 8 weeks. So this is the same with the Thai guideline. So for the European guideline and WHO, so recommend to start ART as soon as possible within 2 weeks of starting ART. But we have to make sure that our patient can tolerate well with anti-TB, because at this time, TB treatment is very important, okay? So if the patient can tolerate well, so don't delay ART treatment. And how about if the patient who are already on ART, if they developed TB later, so the ART should not be stopped, but it should be modified to proper regimen. And another, we're gonna talk later after this. So another important is IRIS. So with the high risk is a CD4 less than 50 or high TB burden. As we use DTG based regimen, it's widely used in many settings with high TB country. So with the DTG, so you can see that the CD4 cell count can be increased very significantly, and also viral load can be reducing very fast within 3 months. So if the patient have very low CD4 cell count, so it's increased the risk of IRIS. If you look at the data from inspiring TB. So they compare between efavirenz-based regimen and DTG-based regimen. So they reported that the IRS was uncommon. But you have to think that because they enrolled all patients with CD4 higher than 50 cells, it's not lower than 50 cells, okay? So we don't have more data. So if we start DTG at very low CD4 cell count, how high of IRS will be developed. So as this a workshop, so I just would like to start with the case. So very young gentleman. So he presented with secondary syphilis with the first HIV positive, very low CD4 cell count, normal chest X-ray, but he didn't have mpox at that time. Okay, so the same day T was started, so we used the TLD, and at the time serum creatinine came back. It seemed to be normal. 3 months later, he was doing fine. His creatinine went up to 1.1. At that time, we think that, oh, okay, maybe because of what? Because of DTG can inhibit creatinine excretion, right? So maybe it's not true abnormal, because these are increased less than 0.5. And then 6 months later, with the HIV viral load less than 50, and CD4 went up to 85, and he's still doing fine, but his creatinine went up. So what do you think at this time? Because of tenofovir, because of DCG, or of what? And then we look at his urine. He has a white blood cell in urine, and AB was positive. No sputum at all, normal chest X-ray. And we did urine lamp, it was positive, and then gene expert ultra from urine, it was detected. So how you can manage this case? A, stop ART, treat TB. B, treat TB and modify ALV to TAP, FTC, DTG, plus DTG in the evening. Or use a TLD, because we think that, oh, okay, maybe it's TB kidney, and then with the additional dose of DTG. Or very easy, consult ID. Please vote. Many IDs here, so maybe you will get consult from this case. Okay, so, maybe I'm gonna ask Tim later. So the most common answer, answer is B, right? Very good. So it means that TAP can be used with rifampicin, okay? Okay, so let's see the data for this case. Before that, so just touch a bit on urine lamp. I think many countries use this as a guideline, right? Including, I saw the guideline from Vietnam, even recently, Malaysia. And Thailand is already covered by national health benefit, and also in the guideline. So just demand that even is, the good thing is that it's very easy to do it, and it can be point of care test. It can assist you for early diagnosis in patient who doesn't have sputum at all. But if you use it, you still need to get culture and gene spread. So this test just assists you for early diagnosis, not to confirm tuberculosis, okay? So the specificity is quite high. But the sensitivity depends on CD4 cell count and whether the patient have severe ill or not. So if the patient have lower CD4 cell count, it's higher sensitivity. Just one thing that it can be false positive in case with other non-tuberculosis like MAC or in urine with contaminated bacteria. So if you see like a asymptomatic patient, you have to think whether this is a contaminated urine or not, okay? And so just go for the ART, what we're gonna do with that? Before that, we need to know, or we need to have the knowledge on what rifampicin will do with the ART. So rifamycin induce cytochrome P450 and UDP gluconosyl transferase or UGT1A1 and also a part of P-glycoprotein. So it can reduce so many ART and other drugs, including velpatasvir for the hepatitis C. So for hepatitis C, if they have TB or if they use rifampicin, you cannot use these two together. And when look at the activity, so as you can see here, so the rifampicin is the most potent of this cytochrome, following by rifampicin and rifabutin. So if rifampicin or if rifampicin can be used with rifampin, so for rifampicin it can be used as well because for what? The induction potency of rifampicin is about 85% of rifampicin. So it's less than rifampicin with daily rifampicin, but will be less with weekly. So why we can use 3 HP with standard dose DTG? Because we don't need the dose modification because it's less cytochrome induction for weekly regimen. So we have to think about both TB, ART, and also other medication, whether they have drug-drug interaction together or not. And as you can see here, DTG is mainly metabolized by UGT1A1 with the minor via the cytochrome 450 and P-glycoprotein. So the rifampicin effect or lower DTG by this metabolism. Just first, I just would like to convince you that DTG, from meta-analysis, the efficacy and safety of DTG is similarly to efavirenz. As everyone knows, efavirenz has long been very good drug for rifampicin user patient, okay? But now we have DTG transition. Many countries don't have efavirenz based right now. So like Thailand, we try to phase out efavirenz to be more DTG based regimen. So for this study, this meta-analysis just show that, okay, efavirenz has similar efficacy and safety with efavirenz, but at the time, very few data of DTG based regimen. And if you look at the data from Botswana cohort, so actually the guideline recommend BID dose of DTG, but some patient or some doctor use QD dose. So as this cohort, you can see that for they look at, they have efavirenz-based regimen, they have DTG with 50 milligram BID or 50 milligram QD. So almost 44% use DTG 50 milligram QD dose. So when look at TB treatment, so DTG-based regimen has a greater TB outcome, especially with the DTG 50 milligram QD dose. And with the viral suppression to less than 400, so the DTG-based regimen also did a high viral suppression, especially with the DTG 50 milligram QD dose. You can see that, so it's no different between QD dose and BID dose in terms of HIV viral load suppression. Just look at this graph of SPRING trial. So I'm talking to you based on my clinician, not pharmacologist. Okay. So if you have more questions, just go to Tim again. So with this graph, they is a multi-center dose finding study in HIV-naive since in early phase of DTG. So they look at the dose 10 milligram here and 25 milligram in the red line and 50 milligram in the green line and also in the light blue for efavirenz 600. What you can see here, efficacy at week 48 is almost the same for DTG-based regimen. That's whether it's 10 milligram, 25, or 50 milligram. And usually, or basically, for pharma, they usually select a higher dose. Let's say efavirenz-based regimen, so we can use 400, or 400 have the same efficacy. But the pharma, they have 600 as a standard dose. DTG as the same, so they pick up the 50 milligram QD as standard. Okay, so just remember this graph. 25 milligram, 10 milligrams is also work. So look at the drug interaction. This in healthy volunteer. So this curve for 50 milligram BID, and also this for 50 milligram QD dose, and this for 50 milligram BID with Rifampicin. So it's DTG area under the curve reduced by almost by half or 54%. And C-mean reduced greater than 70%, 72%, okay? With DTG, this compare to DTG 50 milligram twice daily alone. So that one in healthy volunteer. If we look at, so after that, Dr. Kelly Dooley, so she had another study. It's called Inspiring, sponsored by GSK, and it's multi-center from Argentina, Brazil, Mexico, Peru, Russia, and including Thailand. So they compare between efavirenz and DTG-based regimen and enroll HIV-naive with CD4 cell count greater than 50. So as you can see here, the efficacy was not different between efavirenz and DTG. DTG have lower efficacy because of more patients lost to follow-up, not because of viral failure, but this is ITT. And so for this study, twice daily DTG was effective and well tolerated, and no DTG emerging resistance was observed. So with this study, so it turned, so we, the guideline, many international guidelines recommend to use BID dose with rifampicin because of this study. If you look at the study reported no death, but usually in very advanced case, if they lost follow-up, they have higher death actually, but it's not in the report. How about DTG 100 milligram QD? So if we can use this, it might increase the patient adherence, okay, so with a once daily. When we look at this, this is also in healthcare, in healthy volunteer. This dot line is a DTG 100 milligram OD dose. So here, I don't know whether I just see. Okay. And then the second line is a DTG 100 milligram plus Rifampicin. No, here is here. Plus Rifampicin is here. But this is a DTG 50 milligram QD. And this 50 milligram QD with Rifampicin. So yes, the AUC clearly reduced with the Rifampicin, whether use a QD dose or with the the 50 milligram QD dose or 100 milligram QD dose. But anyway, the study found that even the level is low, but it's still higher than IC90 to kill the virus. So they use a cutoff of about 64 nanogram per milliliter. So with this study, I think that further study in HIV-TB co-infected patients should be explored. Another study just said that, they think that 50 milligram, if you want to use 100 milligram QD, maybe 50 milligram BID would be better. So let's see next whether we can use a QD dose or not. So this data from South Africa. And they enroll the patient with CD4 greater than 100 to receive DTG 50 milligram QD or 50 milligram BID dose as a placebo fashion. And if you look at the data, so they just published in HIV, Lancet HIV last year. So at 48 weeks, so the graph is just for 24 weeks, it's no different. At 48 weeks, the efficacy and safety is similarly between the two groups. So they think that twice daily DTG might be unnecessary in HIV with active TB. So I just would like to tell you here that if South Africa can use it, why Asian people cannot use it? So just follow up later. So Dr. Kelly Dooley also comment for this study that this is a very good data to support QD dose, but if we have if the investigator have more data, what the risk factor of viral failure, that would be more beneficial for many people. And so because for TB study, if we want to do phase 3 study, it usually take longer time. So, and what they think, why QD dose can be used, even though we have suboptimal PK data. So they think that because the DTG binds strongly to integrase receptor with dissociative half-life of almost 71 hours, very long half-life. So with this, so maybe even this maybe can be covered for very short or temporary lower DTG concentration. So why the DTG resistance cannot be observed for this study? So they think that maybe because of the long half-life, and it's very good strong bind of this drug with the integrase receptor. Another study from Uganda, so they use soil sample to develop the population PK. the data is from, they call what, how to call it, several trial. For that time, they look at rifampicin standard dose and higher dose in HIV patients use efavirenz or DTG-based regimen. So on the right, on the left, is a DTG 50 milligram twice daily. On my right hand is a DTG 50 milligram once daily. So for this, the dashed line is represent simulated trough concentration when two formulation used in the higher rifampicin use were assumed to be bioequivalent. So you can see it's lower than expected. So just pay attention. So for DTG BID dose, so all the time, so it was higher than the targeted population, targeted levels, including the higher targeted of 0.3 that was mentioned in spring trial. So, but other study, majority of study, they use a cutoff of this cutoff because of protein at just 90% inhibitory concentration. If it's higher than this, we think that it would sufficient to kill the virus. And if you look at here, so here is a 10 milligram per gig for rifampicin. You can see it's higher than, it's above the targeted population. Even the body weight greater than 70 kilo. So the blue bars, this represents the body weight. Less than 40 is here. So you can see here, so clearly that maybe QD dose can be used. And for this paper, they discuss at the same thing, maybe because of the long half-life and also because of the strong binding site. Yeah. So whether Asian can use this or not, so I think, so we have another data, but just wait for the result. We try to complete it by this year. But so far, we can use, I can say that we can use QD dose. And just for the few minutes left. So with this, just would like to show you the difference between Asian and non-Asian for the drug metabolism. So this A5372, so this study, they look at the DTG 50 milligram BID with 1 HP. So when before the patient received the 1 HP, we did the DTG concentration. And when we compare this without rifampicin, and also this without rifampicin for the Dolphin trial. You can see here, Dolphin trial, almost 60 patients were from South Africa. And for 72, about 30% from Asia is from Thailand. So you can see here, they have lower oral clearance, they have higher DTG concentration. Why I would say that? So maybe for Asia, we can use, we might use a QD dose. Or maybe I just skip this because of the time. So just showing that for the European guideline, the DTG concentration, the DTG is here, so reduced by almost half. So the rifampicin DTG here, so DTG reduced by 54%. So for the HS guideline, still recommend 50 milligram BID dose. And just a bit on the TAP. So for the TAP dose, whether it should be adjusted or not. So this on the for the healthy volunteer, they look at TAP concentration alone, or TAP with rifampicin here, or TDF alone here. So as you can see here, so they look at intracellular. For this, For the intracellular, even though tapped with rifampicin, the AUC reduced almost half, but it's still higher than TDF. It's about 4-fold higher than TDF. For the HS guideline, they state that do not co-administer unless benefit outweigh the risk. But for European guideline recently, just 2 months ago, they add TAP as can be used with the rifampicin as alternative regimen. They still use the old-fashioned with the efavirenz-based regimen, but for alternative regimen, you can use TAP FTC or TDF FTC with the DTG-based regimen. And so I think very good website. You don't need to remember everything, so many things that we have to remember. So for the drug-drug interaction, just use this application. And maybe I just skip this, just show you that with patient with CD4 cell count, high CD4 cell count, long viral suppression, she developed TB later. Unfortunately, she died later after treatment because for what? Spent about 2 months to find out whether she had TB or not because of older age and high viral load. Also, high CD4 cell count and low viral load. And no one think about TB. With the CSLA, think that, oh, it's an old TB. But for the biopsy, it's confirmed TB. So just summary, TB is still a leading OI and cause of death in our patient. So it can occur at any CD4 cell count. The treatment is very complex. Always look at the DDI, or drug-drug interaction. And current standard regimen is still rifampicin based TB is a DCG 50 mg BID, but it is possible that DCG 50 mg QD dose can be safely used with, so we need more data from all of you here to have more data. I just like to end my talk with this slide. So TB, HIV, both diagnosis and management is very challenging. Increased morbidity, and post-TB lung disease as well. So I think prevention is always the best. Why don't we do that? So right now, whatever, start ART early or TPT, and also we have very effective ART now. TLD or TAP FTC DTG is also in the generic formulation and other medication. Very effective and short cost TPT. So we can use 3-HP with the TLD, or we can use 1-HP isolysis rifampicin daily for 74 days. So we have very smart ART, smart TPT, and also smart doctor. So why don't we do that for the TPT? So just tell you for Thailand, so we should promote TPT for the patient. So yes, together we can ending TB together. So thank you very much for my team and for founder, collaborator, and for all of you to attend this talk. So thank you very much, guys.
Thank you, Dr. Anchalee. Does anybody have any questions?
So any question? Yes. I'm sure that you're going to have questions. But Tim, just prepare to answer.
In contrary, my question is about not urine lamp. It's about TPT. You were mentioning about 3-HP and 1-HP. But what about 3-HR in the use of DTG and all the combinations? Thank you.
Yes, for 3-HR, we need once daily isolysis rifampicin for 3 months. So the approach similarly to TB treatment, because we use rifampicin. So it's 3 months. So why we think that it's not, you can use it, but you need to, right now, you need to adjust the dose to BID dose for DTG. But for the 3-HP, it's easier. You can use with standard dose, yes, with OD. And now, the good thing is that we have the generic fixed dose combination of isoniazid, rifampicin. So you can use just only 3 pills for weekly, or if you want daily, so you can use fixed dose plus split dose, so it can be used as well. But for with the DTG, for 1 HP right now, they recommend if you want to use you need to use BID dose. But if you ask me, we have more data, and even the data from Taiwan using with Dolutegravir or Biktarvy or with the DTG-based regimen, so the viral load can be maintained. So without dose adjustment, and we have the data almost more than 500 1 HP cases. So the viral load suppression still higher than 95%. And if the patient with viral load suppression still maintain viral load suppression. So as I show you that rifampicin have less cytochrome induction. So we have the data of DTG with rifampicin, DTG once daily with rifampicin in active TB that usually have high viral load. And with TPT, we usually start TPT later after ART. So that means that their viral load has been reducing at the time. So why we cannot use QD dose? We need more data, but if you ask me, yes, we can use it for Asian population. As I show you from the 5372 that we have low oral clearance. So why we have a higher drug exposure? Why we don't need, why we give them exposed to high drug concentration? Yes, and that's my answer. I don't know, Tim, you have any comments on that? Maybe it's different. Oh,
Okay,
Nick, sorry.
it's okay. I asked my question. So Anchalee, I've got two questions. One, I think you've really covered, but it's back to the PK stuff. The first one is, how common in your experience now is incident TB in people who are stable on antiretroviral therapy? Because I know in the past, when we've tried to do studies of this, people who are already on ART and suppressed, actually we can't find any TB, number one. And number two, the direction of travel for TB treatment, if you're going to use a rifampicin-based regimen, is towards higher dosing. We know we're underdosing at 10 milligrams per kilogram. It's right at the bottom of the dose response curve. There's clear data coming out now that show, even in terms of clinical outcomes, you can get better effects with TB treatment with higher levels. So, you know, you showed some data with 35 milligrams per kilogram, but I'm just not sure of the conclusion for that. Generally, people think that you've kind of maxed out your induction with 10 milligrams per kilogram of rifampicin. So going with higher doses, you don't really get much more in terms of induction. So two questions. One, how frequent is TB really in treated patients? And the second one, what should we do with 35 milligrams per kilogram of rifampicin or the high dose of rifampicin as in study 31?
So thank you, a very good question. So just the last patient. So with that study, when use 35 milligram of rifampicin, so the DTG dose reduction is about 31%. So with the higher dose of rifampicin, so the higher, it's like the more induced, I don't know whether it's true, Tim. And so I mean the DTG concentration will be lower. So it's like if you increase about 10 milligram per kilo per hour more, so it's increased, it's decreased about 2.8%. So totally to 35 milligram, it's decreased about 31% from that study. So if we use a higher dose of rifampicin, so we should go with 50 milligram BID dose of DTG. So we should not go with the QD dose. Okay. And for another, for the first question, actually I have the data, but I don't have the slide now. So yes, in the past, we think that when the patient get ART and the risk of TB should be lower. But when we look at the cohort, the retrospective cohort from 15 hospitals around Thailand, we still found the higher incidence of TB. So mostly after 3 months, 6 months, and then 1 year. So and then even high CD4 cell count and within 10 years of ART, the risk, the incidence of active TB is about 4 times higher than general population. And so if the patient have high CD4 cell count with viral suppression, the risk of incident TB is lower. So I think it depends on whether that area have high endemic TB or not. For example, in Singapore, you might not see incident TB. But for Thailand, so we still have debated on that. Because some hospital, for example, even in Bangkok, in the same area Bangkok, but if you go to Taksin Hospital, if you go to Jula, maybe incident TB is different. I mean, incident TB after ART. Because of the background high TB in that community. So maybe they can have higher active TB later after ART. So I don't know whether I answer your question or not. Yeah.
No, you did that. That's fine. Thanks, Anchalee.
Yeah. Thank you so much. Yes.
Thanks, Anchalee. I would just like to comment that basically when you talk your presentation, we don't need pharmacology anymore, actually, because what you show is that, the target is, we come out with a 50 milligram dose. This is the target levels for AUC, Cmin, for DTG. Then we're basing all of the current dosing with Rifampicin on that. But what the data is now showing is that initial target for DTG with once daily, the target just gets lower, lower, and lower, but the clinical outcome is the same. So I think it's very interesting that that's not always the case, but I think, as you said, if you start with a 50 milligram dose, but 10 milligrams also has equal efficacy, actually the actual target level that they were originally targeting with the 50 is probably over the target needed for, biological, inhibiting replication. So it's an interesting example that how we're saying that, well, actually, this is the pharmacology, but actually we're just ignoring it a little bit, going straight for the clinical and see if that works. So I think it's very interesting in the fact that I wanted to pick your brain a little bit about, in Thailand and Asia, what would it take now to convince guideline makers like yourself to change to say 50 milligrams, once daily with Rifampicin is sufficient? Would you go off the South African data? Do you have to have more data? Because you're going against the pharmacology, but then you have to have the clinical outcome as well.
Yeah. So thank you very much. Very good point. So I think we need help from everyone in the room to have more data of DTG with Rifampicin. HBQ data. I believe that it might repeat the story of efavirenz. So I guess, we start with a higher dose and then with the standard dose. Even the data from African 400 can be used. Yeah. Okay. So thank you very much, Tim. So because of the time, so thank you, everyone.